Hi, my name is Thomas Bianciotto, and I'm in pathophysiology at West Texas A&M University, and this is my presentation on Guillain-Barre syndrome. A little bit about myself. As I said, my name is Tom Bianciotto. I'm in the psych nurse practitioner track. I am married. There's a picture of my wife and daughter, Abby, and my wife is Linda. We moved here to Amarillo from Flagstaff in 2023. My wife's an optometrist at the Veterans Administration Hospital, and Abby just got her big girl bed about a week ago. Briefly about my nursing background, I have been working for the past 6 years at Blue Cross Blue Shield of Arizona. I'm currently on the transition of care team. I call patients when they're discharged from either the medical or behavioral health hospitals to provide some follow-up assistance. I've been doing that for 3 years. Prior to that, I was an integrated care manager or a nurse care manager for seriously mentally ill patients on one of our Medicaid plans. I've worked for a bit in an inpatient psychiatric hospital as an RN for about 6 months. I worked for about 15 months on the general medical services floor at Zuni Indian Health Services in Zuni, New Mexico. And I spent my first nursing job was at a walk-in crisis stabilization unit. And then lastly, I'll mention that I have about 10 years of on and off experience in behavioral health. Prior to becoming a nurse, I've worked as a psychiatric technician and an outpatient case manager for many years. So the objective number one of my presentation is for students to remember and understand basic concepts of GBS. And I'll begin by saying that GBS is an acute immune-mediated polyneuropathy. And there are numerous variants of the disease itself, including some that never fully resolve and can unfortunately become chronic disorders. The occurrence rate worldwide is approximately 1 case per 75,000 people. Both children and adults are affected. The likelihood of the disease process itself increases with age, approximately 2% per year from 10 years onward, and men and boys are more affected than women and females. The pathophysiology, it is a heterogeneous group of acute neuroautoimmune disorders in which all myelinated nerves, i.e. the sympathetic, cranial, sensory, and motor, can potentially be affected. The two most common diseases are the acute inflammatory demyelinating chyloneuropathy, also known as AIDP, and acute motor axonal neuropathy, also known as AMAN. AIDP is the more common of the two, occurs in about 7 of 8 cases. The demyelinization occurs after a localized inflammatory response on both the Schwann cells, which produce the myelin, and the myelin itself. This is believed to begin at the nerve root in the spinal cord, where plasma proteins enter into the cerebral spinal fluid and induce a T-cell attack after immunoglobulin deposition on myelin and Schwann's cells. The demyelinization causes a decreased conductivity of nerves and muscle weakness. Remyelination occurs in the weeks and months thereafter. AMAN seldom occurs in the United States, but it's more common in Asia. The primary autoimmune response is directed at the nodes of Ranvier, which I'm sure you may remember are the narrow intervals of exposed nerve between the myelin sheaths. Very little inflammation occurs, and instead the myelin detaches and the nodes lengthen. Dysfunction of sodium channels, ion concentrations, and intracellular water volume also occurs. Risk factors for developing GBS, first and foremost, the number one risk factor is experiencing an illness that serves as an antecedent event. An initial or viral infection is almost always implicated, in which a cross-reaction occurs between the immune response and the epitopes on the affected peripheral nerves, termed molecular mimicry, is believed to result in autoantibodies that ultimately trigger the neural symptoms of GBS. Approximately 67% of patients report either a GI or a respiratory tract infection prior to Campylobacter-associated diseases such as C. jejuni or C. coli cause acute enteritis and are believed to be the cause of as much as 30% of the antecedent infections. Other triggering events can include those of HIV patients, those with influenza, Zika virus, RSV, pneumonia, Epstein-Barre virus, and cytomegalovirus. Vaccines and surgical procedures have been implicated as well, but the incidence is extremely rare. Clinical manifestations of GBS: bilateral and symmetric weakness of the limbs that starts in the legs and ascends to ultimately include the arms. Unilateral presentation does occur, but it is rare. Reduced or absent reflexes in affected limbs. Autonomic dysfunction, including blood pressure and heart rate abnormalities. Some variations are severe and result in temporary flaccid paralysis, while others are less problematic but still cause weakness. The duration of overall symptoms varies, but most patients typically experience a gradual onset of initial symptoms over a period of approximately 2 weeks. 90% of patients experienced the nadir of the disease process at 28 days, and many patients experience full resolution within 2 months. Objective 2 is to apply and analyze your newfound understanding of GBS to future clinical situations through the process of differential diagnosis. Some of the other differential diagnoses include the chronic inflammatory demyelinating polyneuropathy. This is the chronic condition that I mentioned a few minutes ago. GBS usually resolves within 8 weeks or so, but the chronic condition does occur in approximately 2% of patients. Vitamin B1 deficiency can mimic GBS, but in vitamin B1, patients almost always have nutritional deficiencies and or alcoholism, whereas in GBS, they most often do not. Acute arsenic poisoning is similar as well, but there are characteristic skin and nail changes that should be assessed, and urine is specific for the arsenic. Toxic neuropathy such as glue sniffing can occur, can present as similar, but that is attributed to an environmental or workplace exposure or extreme cases of substance abuse, which would usually be easy for the practitioner to determine. Lyme disease is specific and cerebral spinal fluid is specific to Lyme disease. Tick paralysis is similar as well to the presentation of GBS, but the symptoms resolve upon removal of the insect. Systemic vasculitis, also similar, but the weakness is usually asymmetric, whereas in GBS it's bilateral and symmetric. And disorders of the spinal cord. In those disorders, bowel and bladder dysfunction are commonplace, as is leukocytosis of the CSF. But in GBS, that's not necessarily the case. Objective 3, evaluate how you might alter future practice and create further improvements during triage and treatment of GBS patients. Baseline hemodynamic, respiratory, and neurologic assessments should be performed upon initial presentation and or hospital admission. These include speech, swallow tests, strength of facial and neck muscles, arm and leg strength. When both the timing of symptoms and onset of baseline clinical assessments are accurate, nurse practitioners and other healthcare providers can compare these findings to subsequent and expected declines to better gauge disease prognosis and long-term outcomes. Monitoring respiratory status is imperative, and indications for intensive care unit admission and possible ventilatory support include autonomic instability, i.e. fluctuating blood pressures and or arrhythmias, severe muscle weakness, and or overt signs of pending respiratory failure such as shortness of breath, accessory muscle use, poor pulmonary function tests, etc. Diagnostics and labs needed for further evaluation. Well, first, the symptoms themselves. Primary diagnostic criteria include signs and symptoms, that is, a progressive weakness of the limbs that varies from minor weakness to total flaccid paralysis, weakness of other muscles, including extraocular, facial, and bulbar, which are the muscles in your face itself, decreased or absent reflexes in the affected limbs, and symptom progression of no more than 4 weeks. Cerebral spinal fluid analysis is rather specific. Critical lab value that facilitates differential diagnosis. The normal finding is albuminocytologic dissociation, which is an elevated protein level, likely attributed to increased proteins flowing across the blood-brain barrier in the spinal cord, with a normal white blood cell count. The cell count itself of red and white blood cells is also typically normal in GBS, and nerve conduction studies and electromyography are among other electrodiagnostic studies that should be conducted if possible to confirm GBS diagnosis. Absent H reflexes and either prolonged or absent F waves are the earliest findings. Serial NCS studies can facilitate disease progression and future prognosis. Multidisciplinary treatment is important. The most prominent treatment is immunomodulatory therapy, which is indicated in 2 groups of patients. Those who've had the disease for less than 4 weeks and are either unable to walk independently or have experienced rapidly progressing weakness during the 24 hours prior. The second group, for which immunomodulatory therapy is indicated, are those who have had the disease for at least 8 weeks and are either non-ambulatory and or experiencing respiratory/bulbar muscle involvement. Administration of either immune globulin, also known as IVIG, or plasma exchange can decrease the time to subsequent recovery by approximately 45%. IVIG is the preferred modality because it is easier to administer, can be given more quickly, and has less adverse effects than PLEX. IVIG and other immune globulin medications provide specific passive immunity and prevent further autoimmune destruction of the myelin and the nerve cells. The mechanism of action is believed to be an increase in the number of circulating T cells. PLEX has reduced the rate and duration of those patients experiencing mechanical ventilation and has repeatedly provided better outcomes than placebo in randomized controlled trials. Therapeutic apheresis and immunoabsorption are the 2 modalities utilized. Neurodegenerative disorders such as GBS require a multidisciplinary treatment approach that includes physical therapy for rehabilitation, occupational therapy to address deficiencies in activities of daily living, and speech therapy to address weaknesses of vocal cords, tongue, mouth, and face, and dietary to provide nutrient-rich anti-inflammatory food items. Patient education and teaching. Approximately 40% of patients treated with either PLEX or IVIG do not improve during the following 4 weeks, and approximately 10% will have a subsequent relapse with further weakness. PT and OT should focus on gradual strength training and good posture and limb positioning. Concerns over subsequent vaccination are legitimate. Definitive advice cannot be provided because there is insufficient data specific to post-GBS patients. Most vaccine guidance is based upon expert opinion and observation studies. Generally speaking, the benefits of vaccination outweigh the potential drawbacks of inducing another GBS-related illness. Data suggests that for every approximately 750,000 vaccines administered, 1 case of vaccine-related GBS occurs. Thus, the likelihood of GBS illness appears low, while many patients will likely benefit from the illness preventing effects of the vaccine. The long-term prognosis for many patients is good. More than 50% fully recover within 1 year, but unfortunately 5% succumb to the disease. Those at greatest risk for long-term outcomes include those with a GI disorder prior to onset, those who require ventilation while hospitalized, had severe weakness or paralysis upon admission, and experienced a rapid onset of less than 7 days and are greater than 60 years old. Lastly, the AACN Essentials. Domain 1, knowledge for nursing practice, pertains to the application, translation, and integration of clinical knowledge to distinguish nursing as a profession while fostering innovation and judgment. Competency 1.3, demonstrate clinical judgment founded on a broad knowledge base, is an essential component of caring for GBS patients because the disease process can be life-threatening, has a rapid onset, and can lead to long-term complications or development to a chronic condition. It is imperative for nurses to draw upon the underlying tenets to practice standards such as those developed by the AACN to guide clinical decision-making. Doing so provides the best avenues for collaboration amongst healthcare providers and the greatest likelihood of optimal patient outcomes.